Public Health at the University of Southampton, who has contributed immensely to the public health response during the UK COVID-19 pandemic. She is also named as amongst the most inspiring and influential women globally in the BBC 100 Women 2020 list. So I'll hand over to Nisreen now, who will set the scene for long COVID and give us a patient's perspective. Thank you.
Thank you so much, Sarah. That's a brilliant introduction. Thank you so much for inviting me. Great, thank you. So I'm going to talk 5 minutes just as a general introduction about long COVID. Next slide, please. So just taking you back, the start of the pandemic, where we viewed the pandemic as a black and white picture, where most people didn't get affected much at all, and a minority would get badly affected and die. But then as the pandemic progressed, we now know there is this massive group of people who are in the grey area, who are ill with long COVID, and we need now, there's no excuse really now to confuse survival for recovery. So you can survive death, but that doesn't mean complete recovery. Next, please. I was one of these people where I got COVID-19 symptoms in March 2020, and then I didn't completely recover with this strange, relapsing, fluctuating pattern of symptoms. And I started writing about it in the summer in 2020, really from a public health point of view, in terms of trying to, asking why we're not measuring it, why we're not talking about it, quantifying it. Next, please. So what is long COVID? It's really a patient-made umbrella term. Patients came together, peer supported each other, and this became a popular term, long COVID. It's basically defined as not fully recovering from COVID-19, so not going back to your normal health or baseline health before the infection. It happens in all spectrum of COVID-19 infection, so it happens in mild cases as well, and it can be very debilitating. Next, please. And so we know from the evidence now, it's very common in those who have severe COVID and hospitalized with COVID, whether they get admitted to ICU or not, but also quite common in those with mild to moderate initial disease. And there are differing estimates of, from around 1 in 3 after 2 to 6 weeks to 1 in 10, between 1 in 10 and 1 in 4 after 3 months, depending on the studies. And it's difficult to accurately measure because of that relapsing nature of the illness, and because lots of people didn't have lab confirmation of having COVID infection due to access to testing and the follow-up of the samples being studied. Next slide, please. But from the Office of National Statistics, we've got some a measure of what we're to expect by age group, and you can see that from these estimates, that these are 3 months from the onset of infection, that even children are affected by long COVID, and those who are kind of in a younger age group, those 25 to 34 years seems to have the highest prevalence of persisting symptoms at 3 months. Next slide, please. We still don't understand the mechanism, and it might be more than one mechanism because, as I said, long COVID is an umbrella term. It could be any of these mechanisms in terms of what's going on. Next slide, please. So this is some data about a survey we did in the UK, which was mainly UK participants, but some from around the world. And basically, next slide, please. It shows the most common symptoms, which are in line with other studies that have been done in long COVID. So it's mainly the exhaustion or the fatigue as the most common, but also cognitive dysfunction in terms of memory loss or poor memory, poor concentration, brain fog, and then the other symptoms, which is chest pain or chest heaviness, breathlessness, headaches, muscle aches, joint pains, palpitations, and dizzying. You can see the range, but there seem to be a consistent agreement on kind of the most common symptoms. It's a multi-system disease, so it's a combination of symptoms, rarely just one symptom. Next slide, please. It's associated with a lot of disability. So you can see from these statistics that people have a significant proportion lose income because of having it, unable to live alone, affects their self-care, caring for others, work and domestic chores. So it's causing quite a significant disability. Next slide, please. So as I said, a third say they have functional limitations, severe functional limitations because of long COVID, and very few have negligible limitation. And that is also quite a big proportion in terms of disability, has been reflected in the Office of National Statistics study as well. Next slide, please. These are some research questions. I'm not going to go through them because the slides I think will be available, but there are lots of research questions. There's a lot of unknown in long COVID, which we need to find out. Next slide, please. Important in trying to report, recognize, and research long COVID is to have case definitions. This is quite important, particularly so that we can, there's not much variation in who gets help and support and financial support as well in their sickness. And that's something that needs to be urgently sorted. Next slide, please. Prevention of long COVID is straightforward. We need to prevent people from getting COVID-19 in the first place. If they do get it, we need research to find out what prevents progression from acute to long COVID. And then if they do get long COVID, it's about preventing complications and improving quality of life and preventing disability. Next slide, please. And just to say really that stigma is developing with long COVID in terms of people who, have it, because there's a lot of denial in terms of the symptoms, in terms of what it is exactly. People may be shy away from approaching support and the services because their illness is not being acknowledged because of the uncertainty that we have about it. Next slide, please. And I think we'll go over with the other speakers in terms of, the management and what's needed, but it's really basic. The top thing is listening to people who have these symptoms and acknowledging that we don't know a lot about, what's going on with long COVID. Obviously, there's been post-viral diseases before, but this specific syndrome is not known. And then proper clinical assessment and diagnosis. There might be treatable conditions, underlying pathology that needs to be picked up. And rehabilitation, obviously. So I'm sure this will be touched on later. Thank you very much. Sorry I rushed through this, but it's a quick introduction.
No, thank you very much. That was fantastic, Nisreen. But because of we've got so many fantastic speakers today, we've got to keep to time, unfortunately. So next up, we've got Professor Shashank Joshi, who is a professor of the Indian Academy of Diabetes and a consultant endocrinologist at Livervati and Bhatia hospitals, as well as holding the prestigious position of president of the Associations of Physicians of India. Shashank will now give us the Indian perspective of long COVID. Thank you.
Thank you, Sarah. And I think Nisreen has put up the context very well. And, long COVID is something which we all have seen. We probably have a thinking that Asians in general, or Asian Indians, or Asian Southeast Asian population probably may have a little more predilection to long COVID. But this is all anecdotal. We need to do more data and generation of research. Next slide. So there might be some repetition. This is a nomenclature. Long COVID is more of a lay nomenclature, whether it's a post-COVID viral syndrome, whether it's the long haulers, whether it's persistent COVID symptoms. There's a lot of ambiguity of definition between 3 weeks to 3 months. Some people say it's 100 days, and symptoms recover after recovery also is something what people say. So we really need to define this term and put a taxonomy and ensure that it has a proper diagnostic classification. So that's something which is not done. But now there is a reasonable certainty that between 3 weeks to 3 months is what is probably long COVID, and it could linger longer than that. So that's where it stands as far as we are concerned. We do run a post-COVID OPD, both virtually and physically. Next slide. So obviously, the whole situation, is it a reservoir virus? Is it a virus which is located in reservoirs? It's an unknown pathophysiological question. And whether it's a post-viral syndrome, whether it's immunological is not well known. But we clearly know that it's happening more in the vulnerable population. And we know we get sinus inappropriate tachycardia, we get a little bit of temperature and thermoregulatory issues. But predominantly it is neuropsychiatric and musculoskeletal. So the fatigue is very similar to chronic fatigue syndrome, exhaustion, sometimes tingling and numbness, sometimes a poor hand-brain coordination, and clumsiness. We have seen among healthcare workers also the occurrences of Guillain-Barré syndrome or Guillain-Barré syndrome, and brain fog has been so often talked in the social media, where there is a lack of enthusiasm, concentration, and poor memory. Of course, psychiatric disorders predominantly are post-traumatic stress disorders and fear of death. And of course, we do see a tsunami of lung fibrosis, which is coming up with shortness of breath. And of course, quality of life is something which we now do as a routine on various scales which we use. And currently what we have been studying, and maybe me and Sarah are endocrinologists in this crowd, we are very endocrine focused also. So we have seen two things. One is a small tsunami of hyperglycemia, which comes up with COVID, which could be either pre-diabetes, diabetes, COVID hyperglycemia, or steroids. And then we are also picking up some degree, whenever we have investigated long COVID, I have picked up thyroiditis and hypothyroidism, as well as we have picked up hypocortisolism. So we do need to rule that out before calling somebody with long COVID. Next slide. The clearest, biggest challenge, which is maybe a little not technically in the long COVID space, has been suddenly coming up in the second wave, particularly in India, has been the steroid diabetes and mucormycosis. Because we know if there's a pre-existing diabetes, previous respiratory pathology, immunosuppressive therapy or steroids, some hospital-acquired infections and immune alterations, we are more susceptible for secondary infections. And I think in that long COVID window or spectrum, we should never miss out. And therefore, it's very, very important to control glucose well, appropriately use steroids well, and maintain a very good oral, throat, and a nasal hygiene and cleanliness. Next slide. Clearly, we see this unholy trinity because of widespread use of steroids, and we are seeing a little bit of a mini epidemic of mucormycosis. Just as I talked today, Indian government has now made mucormycosis a notifiable disease, and we know that physicians should be clearly aware of this invasive secondary fungal infections. People have never seen so much of mucormycosis. You know, India is a high reportage country, and obviously we need to use therapeutic agents with the right therapeutic doses, with the lowest dose with the shortest duration. And also we need to discourage people from using broad spectrum antibiotics, especially in absence of infections, and that needs to be closely relooked at. Next slide. So obviously this is my last slide, and you know, post-COVID syndrome is common, and probably at least from the Mumbai experience, I can say it affects almost 80% of COVID affected patients. And you know, it's an anniversary almost a year back on 13th of May, I had COVID, and I had long COVID. So I'm also, like Nisreen, another long COVID survivor. And it's not easy when you actually go through it yourself. We need to understand that this has a very diverse pathophysiology like chronic fatigue syndrome. Probably it affects equally in both genders, at least in what we have reported and seen. We have not published that data. We seek, and I'm going to closely attend this whole symposium to see how best we can collaborate and publish some of the data. And it affects all age groups, making it an element to watch for. Symptoms vary from very mild to debilitating ones, including poor quality of life, almost in half of the patients. And we need a multidisciplinary approach. And recognizing that there is an entity called post-COVID or long COVID is the first step to its containment. Thank you so much, Sarah, for the opportunity, and the Southeast Asian Health Foundation for this wonderful symposium. Thank you.
No, thank you very much, Shashank, for that great presentation and giving us the Indian perspective for long COVID. So I'm now going to move on to Professor Dhruva Chaudhary, who is a senior professor and head of the Department of Pulmonary and Critical Care Medicine at the University of Health Sciences, Rohtak. He has also held the prestigious post of president for the Indian Society of Critical Care Medicine. Dhruva will now discuss the longer term complications of COVID-19, again from the Indian perspective. Thank you.
Thank you, Sarah. May I be permitted to use my video? I think it has been, yeah. Thank you, thank you. Right, I'm just sharing the slides here. Just a minute, just give me a minute. Is it visible? Hello? Yeah. That's what I will just, I hope it is visible.
They are visible. Yes, thank you.
Yeah. Thank you so much. Now, I think Dr. Shashank Joshi has given and before that, Shalini has given us a good overview of what is happening. Myself had it twice COVID, first in the last year, now again this year with the new strain after being vaccinated. And from my perspective, the long COVID has been my voice, which has been going up and down. And probably this sort of a thing we have been seeing in quite a lot of people, and some amount of a cough which is persisting. But nevertheless, when we are looking at it primarily from the long COVID phase, it is one usually expects that there will be a complete recovery. But what is interesting is always we have been writing post-viral fatigue or post-viral asthenia and a chronic fatigue. When you start looking at it, we have been primarily looking from the perspective of the lung. But when you see it, the inflammatory phase, practically every single organ gets affected, including musculoskeletal, CNS, and so forth. So what we find it because of these altered immune systems, we are finding inflammation, infections, and persistence of prolonged system. And along with it, we are also seeing a sequelae of critical care illness and a non-specific effect of hospitalization and deconditioning. So we are seeing a lot of people now who are in an intensive care coming with a neuromuscular weakness, and very rightly said, neuropsychiatric and psychological issues and post-traumatic stress disorders are coming up. In fact, people are talking about the clouding sensorium, but if you see the surviving sepsis guideline, all these things are nothing unusual, has been seen in post-sepsis bacterial, viral, and fungal. The only thing is that because everything is combined together, the numbers are large. People have started talking about it, and one is quite happy. And over and above with the iatrogenic issues which are coming up, which Dr. Shashank Joshi also pointed out. When we start looking at a long COVID, you can have an old symptoms or you can have a new symptom. I think what is very important when you talk in terms of old symptoms or new symptoms is that we start looking at the new symptoms are what are the complications of COVID, which could be respiratory, which could be cardiovascular, which also could be endocrinal. And as you rightly pointed out, that thyroiditis is not an uncommon thing which we are seeing. And also, we must not forget the complications secondary to treatment. And trust me, he has just pointed about rational use of antibiotics. We are seeing a mayhem in our country in terms of polypharmacy and unexplained response treatment which is being going on, and the knee-jerk responses which are there. Now, these are a couple of shadows which you will see. One has seen now quite a few rheumatological manifestations, and these are the inflammatory syndromes. It's not only it has been seen in children. One of my own colleagues in the Department of Anesthesia, as we tapered off the steroids from his first illness, where he had a lung involvement, he had a marked mucositis, including proctitis and oral ones. And along with it, he has started showing his changes in the skin. So my own daughter who had it, we saw in these cases around about 4 weeks down the line, coming up the COVID toe, which came and which disappeared. So it is a multi-system thing. And what we are finding is the adult multi-system immune response. One has seen now nearly 6 cases over a period of last 3 months. And what we are finding predominantly is the persistence of a fever. There is, along with, they may have something like a serum sickness-like illness with minimal involvement of lungs. But dominantly, we are finding is extreme tachycardia and breathlessness in these cases. When you do a clinical radiological evaluation post-COVID in these patients, this is a study which has been published from VPCI Delhi, and here you will find it out that large number of people who are coming with breathlessness. And what is interesting is not that every patient has have a CT involvement. And in this case, I would like to mention one of the studies which has been published from UK itself, where they are finding that even if on the HRCT, you are not finding any abnormality. But the moment you do xenon MRI scans, you find there is a subtle clinical deficiencies which are there and which are accounting for large amount of breathlessness which is there. But still, all said and done, fatigue continues to be the commonest symptom, followed by breathlessness. And that is where what we are saying here, over what Dr. Shashank also talked about, a chronic fatigue syndrome-like picture. And you do a CT scan in these obviously diffuse reticulations, followed by diffuse ground glass opacities. And after that, what we are seeing is organizing pneumonia-like picture. But I think we need to be careful the level, the extent to which steroids and tocilizumab, and now bevacizumab, itolizumab, etc. are being used in India for the epidemic of tuberculosis. I'm just keeping my finger crossed. We don't see that because that is one very big complication which you see with the use of itolizumab in psoriasis. And this is the common symptoms he has also pointed out, which was also pointed by the Shireen also in the beginning, that the unusual musculoskeletal sequelae have been there. Arthralgia, myalgia. I also myself now recall in the first I had a very mild COVID, but I used to walk very briskly. It took me nearly 3 months to come back to my normal walk. So I think they are not unusual. Synovitis probably happens to be part of immune phenomena which we are seeing. But this is again a study which was published by Indian Journal of Orthopedics, where they followed up these cases in their OPDs. Mucormycosis. I'm just finishing up.
Yeah, okay, thank you.
So mucormycosis is there. Yesterday data was 240. The today's data I've got is 268. He has said at Trinity, I think, broad spectrum use of antibiotics, which is rampant, both tetracyclines may also not be altering the mucosa. This is our experience of the 83 patients which have come to us. Fatigue, cough, breathlessness have been there with us. Again, CT showing the similar finding. Practically all these patients who have breathlessness with us, because we run specialty clinic, have a decline in DLCO. But where we were not able to explain, we did a CTPA. We could find 5 cases of pulmonary embolism. And also we did in 10 patients cardiac MRI, where we could find myocardial involvement. And in 2 patients, they were regional. Point I'm saying is you can have a multiple system involvement. And obviously, simultaneously, post-traumatic stress disorder, anxiety continues to be a major part. Thank you very much.
Thank you, Dhruva, for your insights. And now we're going to move on to our next speaker, who is Professor Manoj Sivan. He is an associate professor and honorary consultant in rehabilitation medicine in Leeds. His COVID-19 follow-up study was the UK's first study, which led to the establishment of one of the UK's first community long COVID clinics in Leeds, which is currently considered a benchmark long COVID service in the country. He will now enlighten us with his expertise in setting up a long COVID service. Thank you.
Thank you, Sarah. Can you hear me?
Yes.
Yeah. Okay. Thank you, Sarah, and thank you for thank you for the organization for inviting me for the talk here. Thank you for all the delegates who've joined us. First of all, I would like to say that it's heartbreaking in terms of what's going on in India, and it's heartbreaking for us here. For somebody who's been born and brought up in India. So we dealt with the crisis here, and now, with all the friends and family over there, it's really hard. So I hope we all get through this as soon as possible, and we are all safe. Okay, so I'm going to talk very quickly about, we've got only 5 minutes, about the service we have in Leeds, where I work, and some of the kind of the interesting data. I'm going to talk about an outcome measure which we've developed in Leeds. Next slide, please. So those are the few things Sarah mentioned. We did the first UK COVID follow-up study, which raised the kind of the awareness around the persistent symptoms at 7 weeks, and they are in line with all the other studies, as Nazreen pointed out. So at the back of that, because of the needs, we set up a follow-up. We were looking after these patients in the wards, and then we set up a service to follow them up. And then later it led to a setting up of a community service, because we realized that there are a lot of patients actually who've not been to the hospital. They've had mild, moderate infection, but still having persistent symptoms. So there was a need for a service outside the hospital in the community setting, which could cater the needs of all these patients. And in the process, we developed a patient-reported outcome measure, which I'll be talking about, called the C19-YRS, and it is the first PROM for long COVID. There's been, as Sarah mentioned, there's been some kind of good publicity around our clinic that we've got the right approach in terms of the staff available and the treatments we offer. Next slide, please. So this is how a standard NHS pathway will look like. This is how the Leeds pathway look like, that you have the hospital trust, you have patients being treated in the respiratory wards and other wards, they get discharged. and then they go to the GP, the primary care physician, and depending upon the needs, they are directed to services in the community trusts and primary care, which could be pulmonary rehab, neuro rehab, musculoskeletal, psychology, dietetics, SALT, and other kind of rehab services. So they're generally kind of parallel tracks, which there's no much interaction between these services and there's no crosstalk. And suddenly we are hit by this condition, which is multi-system, and I've got long-term persistent symptoms. And how do we manage? So this is actually, it doesn't sit in nicely in one specialty. So it'll be unfair for respiratory medicine to manage such a multi-system problem long-term, which has got so many kind of angles to it. It's got the dysautonomia, it's got the psychological aspects, it's got the musculoskeletal aspects. So quickly we realized that actually we need what is called as an integrated pathway, where there is different specialties providing input, and we provide that MDT care where there is medics, therapists, and different expertise really. Next slide, please. So this is what we did with the pathway. So we set up the box in the red, which is the COVID MDT, predominantly in the community outside hospital, but linking in to the hospital as well. And then the patients got triaged at discharge using our C19 virus scale. And depending upon the needs, they got a subsequent triage, and then they got diverted to these various services. So the ones with complex needs, which long COVID is, they would go to the MDT. The plans would be laid based on their presentation, and then they will be directed to these various services. So the service which we set up in the community actually drew the specialists from these various existing services, and new posts were created, and we created that MDT where you had expertise coming in from all those different services. So very quickly, we changed that parallel track approach into an integrated approach. And this is what happened in Leeds just after the first wave. Next slide, please. So, and this is what we just published. This was, I mean, you have Emmy talking about this study later, which basically highlighted the multi-system problems which are seen in patients long-term. And we wrote an editorial on it saying how we need this integrated approach, not only in UK, but elsewhere. It applies to India as well. Next slide, please. So this is what we need, managing patients. We need a comprehensive medical assessment. I think we need a general physician really leading this service, who has a grasp of all the different systems, who can systematically screen the multi-system for problem, initially manage them, work out all the red flags, whether this is cardiac arrhythmia or whether this is a pulmonary embolism. So somebody who's experienced enough to screen and manage those, then lay out an MDT approach where the rehab comes in, which is either one-to-one or it's a group therapy. Next slide, please. So this is what we've got in that team, in that red box. So we've got a physiotherapist, occupational therapist, respiratory nurse, respiratory physio, dietitian, occupational therapist, consultants in rehab medicines, our specialty. And we've got respiratory medicine and cardiology providing input in MDT, which happens once a week. And it's a new project. So we've got project manager, we've got research input, and we've got psychology as well. Next slide, please. So this is the outcome measure I was talking about. So this is basically, it has got 15 items, 10 items on symptoms and 5 items on the functional disability. Each symptom has to be scored on a Likert scale of 0 to 10, which gives you an idea of how severe that symptom is. And as Nazreen was saying, it's a fluctuating condition. So having it on an app actually provides you the ability to track the fluctuation across time. So now this scale is available on an app, and more than happy to share details of this with Indian colleagues if they want to use this for screening people and also for monitoring them and managing them and assessing really the response to the treatments you're offering, whether the severity of long COVID is coming down and what's happening long term. So it gives you a symptom severity scale, it gives you a functional disability score, and it also gives you an overall health scale. And at the moment for long COVID, this is the only scale available as far as I'm aware. There's few others being developed. Next slide, please. So this is how actually some of the initial data coming out of our center looks like. This is 200 patients, and we can actually, what's interesting is when you look at all those different symptoms, they seem to be somehow hanging together. So you get these phenotypes of mild, moderate, severe. So if somebody is mild on a Likert scale of one particular symptom, they would be mild on the other symptoms as well. This is something which we were not expecting to see, because people always talked about phenotypes being driven by one specific symptom. But what we found is actually they all are hanging together, and you get these phenotypes of mild, moderate, severe. Next slide, please. So that's the functional disability, again, hanging together, those three phenotypes. Next slide, please. This is another way of presenting it, the three phenotypes. Next slide, please. And this is how to manage some of the common symptoms. What's the approach to be taken, whether it's medical management or rehab management. And I'll share a slide on references. It's all detailed in that paper of ours recently published. Next slide, please. And that's just, we'd also do an MDT program, a 6-week program for these symptoms, and that's detailed in there. Next slide, please. So summary is, well, it is the next biggest healthcare crisis, as previous speakers have highlighted. India with 25 million will have around 2 million people with long COVID, and probably more to come. And we need an approach. We need guidelines, we need policy, and we need an integrated kind of pathway approach with a proper understanding of phenotypes and personalized rehab interventions. Next slide, please. The global strategy is, I am kind of involved in that in my WHO role as COVID rehab consultant. So the top paper there, which I've underlined, that actually lists very nicely how to approach these patients and how to manage individual symptoms and what are the rehab interventions needed. And happy to share details of any other papers there listed on long COVID. Next slide, please. Yeah, so that's me. Thank you. I've put my email address there, so people would like to get in touch with me, please drop me a line. I'm more than happy to share our experience. Thanks.
Thank you, Manoj. Thanks, superb work. And I know that you'll be leaving us early today, but if we have any questions, we'll try and get them to you at the beginning of the question and answer session. Okay. So now we're going to move to Professor Mahesh Kapanayil, who is a pediatric cardiologist with technical expertise in interventional pediatric cardiology and advanced cardiac MR imaging. He impressively leads the first in-hospital medical 3D printing lab in India at Amrita Institute of Medical Science, Kochi. Mahesh will now discuss the longer-term considerations of COVID-19 in children. Thank you, Mahesh.
Thank you very much, Sarah, for the introduction. It's a pleasure to be here. And I'm here to talk about the longer-term considerations for children. And we must understand that children have some very, very special issues with respect to pertaining to long COVID, which actually goes beyond long COVID. These issues can get particularly amplified in countries like India and maybe some other resource-limited environments. So what do we mean when we talk about long-term considerations here? Long COVID, does it exist as an entity in children? There is still scant data. We're still looking at the answers. But there is something that we have observed over the last year, which is called multisystem inflammatory syndrome in children, which actually occurs somewhere between 2 to 8 weeks after COVID. So definitely this is something that is happening in the longer term after COVID. What happens to children after they get exposed to MISC? That's again a question that begets really begs for answers. And there are several non-clinical implications as well. So to look at the first question, whether long COVID, whether it exists in children at all, the data is really, really scant globally. This is one of the first studies on looking at long COVID in children, looking at children from Italy last year. And 129 children who were diagnosed last year in this Italian study. Out of them, nearly 53% of them had at least one symptom on the longer term, and at least 43% of them were impaired in their function by their symptoms. And most of these children who had long COVID, so to say, were mostly symptomatic children, or those who were hospitalized during acute COVID. And insomnia, respiratory symptoms, fatigue, myalgia, arthralgia, lack of concentration, etc. were the spectrum of symptoms that were seen. This is a recently published study from Royal Children's in Melbourne, a single center study which looked at 171 children from 137 households with a median age of about 3 years, and they were followed up for a period of 3 to 6 months. And in this study, they found that about 8% of children, all of whom were symptomatic during their acute COVID, had persisting symptoms, mainly revolving around cough and fatigue, lasting about somewhere between 3 to 8 weeks after the acute COVID. There's very little data. There's one more report on 5 Swedish children, again reporting symptoms which persisted for 6 to 8 months after COVID. This was a media report, so to say, from UK advocacy group looking at long COVID in kids, which claims that it has information on 1,200 children in the UK, and they reported that nearly 13% of children between the age of 2 to 11 post-COVID had persisted to have symptoms 5 weeks after the initial COVID. And nearly 15% of children between the ages of 12 to 16 continue to have symptoms 5 weeks after the initial infection. So the data on long COVID in children is very, very limited globally, but we do have lots and lots of data that is coming up on MISC, or the multi-system inflammatory syndrome in children, seen somewhere between 2 to 8 weeks after the COVID occurs. And there's a lot of data even from India. At my own center, we've looked at data, and we have seen nearly 40 children in our own center over the last 3-4 months. And even today, I was dealing with a really, really sick child who came with an almost flatlining ECG, whom we had to temporarily pace. And these children, it's very, very important to recognize them in time and give immunomodulatory therapy to save them. And the spectrum of the syndrome is quite wide. We recently reported in the Lancet on the multisystem inflammatory syndrome occurring in a newborn child after the baby was exposed to COVID in the prenatal period, with a mother getting COVID in the 8th month of gestation, and then the baby going on to get an inflammatory syndrome. So the spectrum is so bizarre and so wide. And what happens to these children after MISC is an important research question, because in MISC you have inflammation of the heart, the liver, the kidneys, the central nervous system. What happens to them after that? We need to really collect a lot more data on these aspects. But there are several non-clinical ramifications of COVID too, particularly in India, pertaining to, say, nutrition. What happens when a newborn baby is separated from a COVID positive mother? Should the baby be separated or not? Is nutrition more important than being protected from COVID? The economic impact of the lockdowns and the educational impact of the schools being shut and the children being forced to online learn, which is very, very challenging in a country like India. The psychosocial impact of social distancing and of lockdowns, it's having immense impact on children. And the children are also being deprived of the opportunity for emotional and intellectual development during this particular period. So there is really a huge lack of data. We need large registries to really quantify all of these aspects. And children and COVID is really this huge elephant in the room that most people are really, really uncomfortable talking about. And it's been a challenge for me as a pediatrician to raise awareness about even MISC, even among pediatricians in India. And sometimes even doctors tend to normalize vague symptoms in children, which makes it more difficult for parents to really report about, vague symptoms that the children have after COVID. And there is overall a reluctance to acknowledge the possibility of longer term health implications in children, particularly in children following COVID-19, at both governmental and societal levels. So these have great implications, not just for the clinical care, but for designing the vaccination strategies for children, supporting the psychological and mental health, and creating social support systems, and strategizing schooling, education, and overall engagement of children. Thank you.
Thank you, Mahesh. That was a superb presentation. So we're now going to move to our last speaker, but not least. So Professor Amitava Banerjee is a dear friend of mine from medical school, but also a trustee for the South Asian Health Foundation. Ami is an associate professor in clinical data science at University College London and an honorary consultant and cardiologist across University College London and Barts NHS Trusts. He has a special interest in heart failure, atrial fibrillation, and the role of informatics and electronic health records in delivering better patient care. With his strong research background, Ami will now give us the research perspective for long COVID. Thank you.
Sarah, thank you so much for the kind introduction, and thank you to everybody organising, and particularly Thank you to people listening in from India. Next slide, please. I'm going to reiterate a lot of what's already been said, but firstly, I'd like to say that we have to consider long COVID in the context of the pandemic. Part of the reason it's not been on the radar is that we've been focused on the acute hospitalized burden from COVID, which is currently in India, but it's been on our shores in the UK several times this year, swamping the health sector. And so the easiest way to avoid long COVID is infection suppression at population scale. We mustn't forget that, to avoid both the early mortality that we've seen from COVID, but also to avoid the so-called long tail of the pandemic in the form of long COVID. We showed that in hospitalized patients, there are long-term consequences on organ function. So in the BMJ, we did an analysis of nearly 50,000 people in the UK post-hospitalization to show that outside of the lungs, in terms of diabetes, cardiovascular disease, kidney disease, liver disease, there are consequences in people who are discharged, and there's a readmission rate and a mortality rate there. So again, avoiding infection is important, if possible, as the first step. There's a long-term impact even in non-hospitalized people. We focus on the hospitalized people, but there is significant impact on people's function, which means that people might not be able to return to work. And this has a huge impact on our societies because it seems to be particularly in younger adults, not just the older, more vulnerable people, who are more affected in the post-hospitalized cohort. We don't yet know very well what are the predictors of long COVID in the first place. It's not just related to severity of index COVID illness. And so we need more data on that. And we haven't got around what are the predictors of recovery, and there are still no proven treatments or proven rehabilitation strategy. And so those trials are pending. Next slide, please. This is related to Nisreen's original slide, but just to reiterate, the best way to avoid long COVID is infection suppression and vaccination. And if you do get infected, then we need to have systems in place to recognize the symptoms of long COVID and assess them and monitor them. And as this is a disease which we are treating at the same time as we are defining. My colleague Mel Heitman, who set up the clinic in University College London in May of last year, says that we're building the plane while we're flying it, which is not a position we want to be in, but that means that gathering data is important as we go along. Next slide, please. The blind men and the Indian elephant is an important metaphor here. Our medicine is gathered around different specialties and different silos, and that's not helpful in this new illness because we're all looking at different parts of the elephant and not seeing the overall elephant. So we do need, as Manoj has eloquently said, to be integrated and look across the silos. Next slide, please. Next slide. Oh, sorry. So just to finish off, prevention of infection is best. We need to think broadly in the context of the pandemic. We need to think integrated care. And this is an issue that needs to be thought about globally. There's far more funding and resource, including human resource, for the acute hospitalization and the acute care naturally. But we need to make sure that there is resource to treat the long-term consequences. And we have to listen to our patients. Thank you.
Thank you, Ami, for that a fantastic presentation and the excellent analogy. So it's now time for our panel discussion and question and answer session. Can I please ask all the panelists to switch on their cameras? I'd also like to introduce Dr. Amit Saraf, who is also joining us for the question and answer session. He practices as a consultant physician and DNB teacher at Juniper Hospital in Mumbai. And I will now hand over to Dr. Alison Tavare, who we're fortunate to have to chair the question and answer session. She's a GP lead in West of England, AHSN, with a specialist interest in COVID. Thank you.
Thanks very much, Sarah. And thanks very much for all the panelists. I've learned so much as a GP. It's been really excellent. And thank you also for all the people who've been answering some of the questions in the chat, because obviously we haven't got a huge amount of time. So we hope that that's been helpful. And in addition, some of the questions asked haven't been on long COVID today. So can I refer you to the SAHF website, because we've had a lot of other previous webinars which might help you with those, getting some of the answers. So some of the questions I've got are varied, but the first one I would actually like to pose to Amit is, when should a patient actually start visiting for long COVID? When should they start seeking help?
Thank you, Alison. Pretty pertinent, because everybody here has done an excellent job of telling what long COVID is all about. The way we see it as clinicians, most of these symptoms, if you see through them, sound like symptoms who are of not a dramatically sick person. He has a bit of brain fog. He may be a little tired, a little of malaise, maybe a little feverish. So the question then is, what is the red flag they should be noticing for which they seek medical attention? They just can't lying in their home or in their beds trying to get better. So the answer to this question, the red flags which the patient should look for in long COVID are primarily the vitals, which include your temperature, your pulse, your blood pressure, the oxygen saturation, sugars if you're a diabetic patient as well. Symptoms like increasing breathlessness on simple exertions like walking to the washroom and back, low appetite, if you're a blood pressure patient, your blood pressure shooting up. So if you notice these red flags, then that's the time to rush to your GP or a doctor and get yourself evaluated.
Thank you very much indeed. Thank you. And then the next question I'm going to ask is to Nasreen. You spoke about prevention. It's come up a number of times in the discussion. Primary prevention, obviously, we prefer not to get COVID in the first place. And unfortunately, for a lot of you on the panel, that's not been, you've all had COVID already. But you spoke about secondary prevention. I know you say there's nothing specific, but a number of questions. Any ideas of how we might people might prevent themselves getting long COVID, or how people can help themselves?
Thank you, Alison. So before I answer the second question, the first point, I think even for us who had long COVID, I think it's really important to stress that we want to prevent reinfection because it can happen. So, vaccinations, because there's a lot of, there might be some, I don't know, there's some hesitancy about vaccination long COVID, but I think I would think it's definitely recommended to, at least for the primary purpose of preventing reinfection, particularly if you had it bad in the first time round. Secondary prevention, I'm not aware of any pharmacological treatments so far, but I think that's mainly because there hasn't been that focus, particularly on the not so severe cases of acute COVID. One thing that's been suggested and recommended for people on COVID, for people who with acute COVID, is to get adequate rest and not push themselves. There seemed to be a theme in people who have developed long COVID, is that they kind of tried to go back to their normal daily activity quickly, not got adequate rest. In our survey, we did similar. We couldn't compare to people without long COVID, but we had two clusters, one with severe cluster of symptoms which weren't getting better, and another cluster which seems to be getting better. And I think that kind of correlates with Manoj presented as well in terms of the severity of phenotypes. And it seems And it seems that the people who were getting better, the cluster who were getting better, have reported that they've rested more, had adequate rest in the first 2 weeks of the illness. But there are all sorts of, it's an observational study and it's a survey, so there could be some bias in terms of the reporting there. So that's, I don't know if the other panel would want to say something, but I think it's important also not to stress people about rest, because some people just can't get weeks and weeks of rest after having acute COVID. They have to go back to work, you know, they have to care for their families and children. So I think we have to be careful and sensitive about this message as well.
Thank you. It's very interesting about the graded return, because actually I used to work in professional cricket, and one of the things we found after head injuries was that if we could stop people exercising and resting from using screens, they actually recovered much more quickly after a head injury. And you kind of wonder about this multi-system response. No evidence for that, but that's just an interesting observation. So thank you for that. The next question is actually for Shashank, and one of was posed in the chat was actually, what about the prolonged subfebrile response? Is this something you've been seeing?
Yeah, absolutely. We do see a evening rise of fever around 9900 degree Fahrenheit, which is probably a variable thermoregulatory response, and sometimes can last right up to 3 months. Two things which are very unusually seen in some of these cohort is sinus inappropriate tachycardia and thermoregulatory response, particularly evening rise. And usually after a couple of weeks, it settles down, usually lasts for 6 to 8 weeks. And we have seen this. And probably there is something to do with the thermoregulatory or the hypothalamus, is what we presume. But as I said, this is all anecdotal. We need to document, collaborate, and do some good science around it.
Thank you. That's very interesting, particularly if we're looking at predictors for long COVID.
And Dr. Allison, there is something very interesting. If you give me a add to it, the fever comes at the same time. That is something very interesting observations. Is suppose somebody even in the acute COVID also, if you're getting high fever, let's say in the morning, and that is the time within 2 hours or 3 hours of that, the same pattern we are seeing, and probably nearly 5 to 6% of our cases are continuing to have these symptoms along with malaise and all. So that's what we have been seeing, observing, and the question that comes out, how to handle it, because we are trying to look entirely in terms of a chronic fatigue syndrome and other things, but patients are extremely anxious, jittery, so are the physicians. And quite often you will see, and I hope Shashank will agree with me, either you end up using indomethacin or you end up using, in fact, a small dose over a little longer point of time for the corticoids when you are doing. This is what is being happening and being practiced, but no specific guidelines are there.
As you say, it's going to be an area for evolving evidence, which is why we need to be all doing research, isn't it, and looking at what's happening. So I know that unfortunately managers had to no longer able to stay, but you can see the value of his app collecting information. And another question for Amitava. This was posed in the chat, asking, is long COVID more common in Asian populations? Sorry, Ami, I didn't ask you that. Do you know that? Has there been any evidence, since we know that COVID itself is in the UK is more common?
Yeah, thank you very much for the question. So unlike the disproportionate effect in the mortality, which has been observed in national data and many different research studies in the UK, in long COVID, we haven't seen such a predisposition by ethnic minority versus white yet, and we haven't seen evidence that South Asians are necessarily as prone to the consequences. But we need to keep gathering data, and we can't assume that South Asians in the UK equals Indians and Pakistanis and Bangladeshis. So I think gathering information is the only way that we can know and treat a new disease.
Thank you very much. I'm aware that it's coming up to 5 o'clock, and I don't know if there are any other questions. I was looking, Dr. Mahesh, was there anything else you wanted to kind of mention? Because obviously you spoke about children. Is there anything else that you wanted to highlight, having heard about long COVID in adults?
Yeah, the only thing I wanted to really say is that, talking about children and COVID and post-COVID issues, really, like I said on one of my slides, is something that people are very, very uncomfortable talking about. Even when we try to spread message about MISC and risk to children, say on social media platforms, people are very resistant to, they seem to just listen in from one ear and take it out of the other. They just don't want to focus on it. Perhaps because it is so close to people's hearts that, they're scared to think of their children falling sick. But I think it's a very, very important public health message that has to go out there, that children need to be really, really protected. Like in the last 3 days, we've been having this huge peak in India, right, on the surge. In the last 3 days, I've had 5 children coming in really sick into my ICUs with MISC, with all kinds of presentations, including a child that came in today morning with almost flatlining on the ECG. The child was referred as a complete heart block, but the child was actually in an idiosyncratic rhythm, and we had to put in a temporary pacemaker, start IVIG emergently, and the family seemed to be just unaware that the child was ever at risk, because the only history that was there was that the father of the child, this is a 3-year-old child I'm talking about, and the father of the child had COVID a month back, exactly a month ago. So the child was exposed to COVID at that particular time, and now exactly 4 weeks later, this child just collapses. And we're not sure whether we'll be able to save this child. But then, and we in a tertiary hospital are only seeing the tip of the iceberg. I'm sure that there are a lot more children falling sick in the community and not able to really reach a center where IVIG can be provided. And intravenous immunoglobulin is really expensive in India, and we don't have a system by which it can be provided or subsidized or made available at smaller centers. So it's a huge problem. I think we need a lot more public health messaging about keeping children safe. And then we are also beginning to see more and more problems in newborns born to mothers who've had COVID. And this is again something that even established pediatricians are finding it very difficult to accept that this could happen. And but we are seeing it. And these children have really raised inflammatory markers. They behave completely out of proportion to their other clinical spectrum. So I think this is really important.
Thank you very much for sharing that. So it's really quite a challenging story, but hopefully, as you say, by these webinars where we can share expertise and learning, we can try and find some way to go forward.
Yeah, Dr. Allison, somehow this is something very interesting. In the first wave, we didn't see so much of children. What we are seeing in India this time, getting it up. In fact, as a state nodal officer, Shashank is also looking after Maharashtra. I look after the northern state of Haryana. We went after the pediatricians to come up with a protocol. In fact, we have to cajole them, tell them we have started seeing them. Because in the first wave, what we saw more were the neonates who were born to ladies who were having it this time. Another thing which is happening is that somehow it has hit with ferocity the pregnant ones a lot now. So now with my intensive care unit, now 3 pregnant ladies are right there. And one of our doctors at one of the 100 kilometers from my place has to be taken on ECMO. Fortunately, she did well, delivered well, the child is well, and it's a happy story. They've all gone home. So the point is that obstetricians have accepted it. They are working well. I agree with him. But at the same time, I may say that at certain state government levels, we are like providing tocilizumab and other drugs, including now amphotericin free of cost, so that wherever it is available, people are using it. IVIG is coming in that group, and we happen to use it in 2 cases, but they were all adolescent. So I think probably awareness is required, and the multisystem inflammatory disease, I think we need to be aware about in adults too. It's not that the pediatric age group is coming up.
Yes.
At around 4 to 6 weeks, we are seeing even adults are coming up, and we need to be very, very careful.
Absolutely. There is probably an MISA and
Yeah,
an MISN for newborns and MISF in a fetus. I mean, it's a whole spectrum.
Gosh.
MISA for sure.
Thank you for sharing that, because in fact, one of the areas we were thinking of doing for a future webinar was COVID in children. And certainly as a COVID lead, one of the things we've also been doing is looking at national principles of practice and how we should look after our patients who are pregnant and happen to have COVID at the same time, so we can have principles for care. But I think that's going to be a future webinar. So thank you all for all the panelists. I hope we've answered most of the questions. Apologies if I've missed some of them. And I'm now going to hand back to Sarah. So thank you very much.
Thank you all. Thank you so much for all your time. So that brings us to an end. The videos and slides for all the webinars, including tonight's, are available on the SAF website. The certificates will also be sent out in due course, so please do show your patience. Don't forget, our next webinar in the series is on Monday, May the 24th at 4 p.m. British Standard Time, and that's 8:30 p.m. Indian Standard Time, and it's on palliative care and COVID. And finally, I would like to give my huge thanks on behalf of the South Asian Health Foundation to our esteemed panelists for their time, their superb presentations, and their fascinating discussion. It's been really food for thought. And I want to thank Harpreet Sood and Sonali Kinra for their immense hard work in getting these webinars off the ground, created and organised. For Alison for chairing the question time, Raj and Bernard for all their help, and all our collaborators for their support with these webinars. But lastly, but not least, thank you to all of the attendees for listening, and don't forget to fill out your feedback surveys. Take care and stay safe.
Thank you, Sarah. Thank you, everybody.
Thank you, Sarah, and thank you, Amitav, giving me a chance to come and share my experience with you people. Thank you so much.
Thank you.
No, thank you.
Thank you very much.
All superb, absolutely superb.
Thank you.
Thank you. Bye-bye.
Bye.